Hello, my name is Charlotte Rift. I'm a PhD student and pathology resident at Department of Pathology at Copenhagen University Hospital, Rigshospitalet. On behalf of my co-authors, I would like to thank GI Endoscopy for the invitation to discuss our recent publication called Endoscopic Ultrasound Guided Through the Needle Biopsies of Pancreatic Cystic Lesions, a pathologist guide for the endoscopist. We did this review because we felt that there was a need for a standardized guideline for tissue processing and microscopic evaluation of through the needle biopsies or TTNBs from pancreatic cystic lesions. As is well known, the diagnostic evaluation and management of pancreatic cystic lesions is difficult. The sensitivity of fine needle aspiration is low, and this is primarily due to a low cellularity of the cyst fluid. So we were very excited when the microforceps became available and it was possible to obtain a microbiopsy of the cyst wall. We have evaluated more than 100 TTNBs at our lab, and where cytology samples contains loose or fragmented cells. The TTNB usually presents as an intact small section of the cyst wall, and you get to see the anatomical relation between the neoplastic cells and the underlying stroma. And this is not otherwise possible by cytology. The TTNBs are very small, usually 1 millimeter in the largest cross section. So we quickly realized that after evaluating the first slide of the biopsy as a hematoxylin and eosin stain, we had to prioritize regarding which additional immunohistochemical stains to perform due to the scarcity of the biopsy. So you really have to take a close look at the biopsy and decide on a reasonable tentative diagnosis and differential diagnosis so you can perform the correct immunohistochemical stains to confirm or elaborate upon your diagnosis. This has not been reported in a systematic way in the published literature beforehand. So as part of the review, we developed an algorithm on how to work around these diagnostic issues you encounter as a pathologist when dealing with TTNBs. The algorithm begins with an initial evaluation of the sample where you decide if both epithelium and stroma are present. And then, roughly speaking, the algorithm divides the cystic lesions in mucinous cysts and non-mucinous cysts, and also integrates the grading of dysplasia using a two-tiered system of either higher or low grade of dysplasia. Of course, you have to consider representability issues, as the biopsy only represents a very small excerpt from a larger cystic lesion. Whereas the cytology sample obtained by fine needle aspiration of cyst fluid contains cells shed across the inside of the whole cyst and hence represents the entire cystic lesions, at least in theory. But the role of heterogeneity of pancreatic cystic lesions in relation to the diagnostic evaluation presents an entire field of future study to pursue. In the review paper, we also dwell on the importance of the close collaboration between pathologists and endoscopists. For example, it is crucial to report the puncture site in the endoscopy report for the pathologist, because this information is very useful if contamination of the sample is suspected and we have to use immunohistochemistry to distinguish between a cystic lesion and contaminating tissue. So in conclusion, TTNBs are promising for the diagnosis of pancreatic cystic lesions. In the future, I hope prospective studies will be performed with sizable surgical cohorts, so we will gain knowledge about the role of tumor heterogeneity. Thank you for listening. I hope you will find our paper interesting and useful for your future diagnostic work.